Good morning, everybody. Let me just get myself a little bit better situated here. Uh, Sitting in the audience, you might not realize that those of us sitting at the table have no idea what the slides look like. So I was worried for a second, like it's a good thing I genuinely memorize my presentations before I deliver them, just in case I couldn't see them, but we do have them right in front of us. So I wanted to start out. One of the things you discover when you do a lot of presentations is you don't actually have to follow your slides. And I've heard a lot of things I think are really important to emphasize that I think are relevant to San Diego County and how we are approaching the HIV epidemic. And the first is that to acknowledge that the County of San Diego actually does have a Getting to Zero initiative that we developed in 2014 and 2015 and implemented on March 1st of 2016. First thing I want to start out by saying is that we didn't name it. That name came to us from the Board of Supervisors. It's an initiative that comes from our elected leadership. And it came, of course, from the UN Program on AIDS Getting to Zero plan. And I want to point out that Getting to Zero and End the Epidemic are both problematic in how we phrase them. It implies somehow that the efforts that we are engaging in will end 10 years from now, and that is exactly the opposite of the truth. As we figure out how to get better and better at this, we are going to have to continue doing this for decades. And we need to make sure that we are messaging that over and over again. And the urgency for this, for me, comes from looking at what happened with syphilis. So if we look at San Diego County in 1998, we had 26 cases of infectious syphilis, 26. And resources were deployed elsewhere because, oh, we got this is not a big deal anymore. Well, we ended 2018, we haven't finalized our 2019 data yet, but we ended 2018 with 1,100 cases of infectious syphilis. And so if we do not think about how we continue to advocate and emphasize the importance of continuation of resources for the populations that we are working with, we might achieve something, but we are very quickly going to see a rebound, and we don't want that to happen. Another piece that I wanted to touch on really quickly is just how complicated the systems we all navigate are. From an administrator's perspective, all the different funding sources, I'm glad this came up a couple of times, all the different funding sources that we have to navigate, all the different requirements, all the different forms. What is that like for our clients when we're trying to get them into care? We are doing our best to try to make these seamless systems, but my gosh, it is so hard to actually have to do that. And so as we think about going forward, I really encourage us to think about what do we do to make it easier? What do we do to remove as many barriers as possible to care? How do we streamline our approaches so that getting care in agency A is the same process as getting care in agency B? Yeah, thank you. I want to give a quick ditto on STDs. I have been in public health now for 8 years, and they have not been good years for STDs. And by way of comparison, I get about $18 million a year to fight HIV from state and federal resources. From state and federal resources, I get about $500,000 to address STDs. And I don't just want HIV added to STDs, I want the same amount of resources dedicated to STDs that we are currently dedicating to HIV. Think about what we could do. And then finally, I want to ditto Mario's comment on the importance of surveillance. I'm going to talk about this a little bit more. In our work in Getting to Zero, we have discovered how vital our surveillance data is, and we've also discovered how much work we need to do in our surveillance data. That with the fact that we don't have real-time surveillance data is a real problem because we are looking at where the epidemic was a couple of years ago or 12 months ago. We're not necessarily looking at what's happening in the past couple of weeks, and we really need to think about how we do that. And this became really apparent to me when we embarked on Data to Care several years ago, working with our colleagues at CDPH, Office of AIDS, providing amazing line lists. But we discovered, we thought, gosh, it's just gonna be really hard and we're gonna uncover all these barriers that people are experiencing in getting into care. The most surprising thing we discovered was that 2/3 of the people that we thought out of care weren't out of care. Now, part of that is unique to San Diego and some of the healthcare systems that exist in San Diego, but it told us that the picture our surveillance data was telling us was a little bit darker than the reality. It told us that we were doing more poorly than we might have actually been doing. And so it told us that we need to do some work. I want to acknowledge, by the way, our surveillance coordinator, Dr. Samantha Tweeten, is in the audience. You are a data goddess. We couldn't do this work without you. So the county's, really quickly, the County's Getting to Zero initiative has 5 key strategies: test, treat, prevent, very similar to lots of other strategies. There's 2 that are not, I don't see a lot, and the 4th one is engage. From the outset of our initiative, we talked about how important it was to work with the communities disproportionately impacted by HIV so that they have a voice in what we are doing. They have decision-making authority in what we're doing. It help create the agenda with what we are doing. And it's so important because the past, whirlwind of the past 6 months, that has not been the case, right? It's been this mad dash to bring in funding to complete applications without having gone out to our communities to talk about and educate them about this new initiative and how are we going to do this together. So our goal now is to back that train back up into the station, get our communities back on board, and create shared agenda with them. And then finally, improve. We don't talk a lot about quality improvement, which I think is too bad. As a data nerd, it's so important to look at how we're doing against benchmarks or against the goals we set, and then figure out how do we do better. Overall, since 2016, from 2016 to 2018, that 3-year period, we saw a 27% reduction in new diagnoses. So yeah, it's a really amazing accomplishment, but you also notice that the slope of that decrease is flattening out pretty quickly. So we've gotten some of the easy stuff done, but the really hard parts are coming up. And there are 6 populations that we are really focusing on in intensive ways. Populations that are experiencing not the same outcomes. Persons who inject drugs. We are a county that continues to have a prohibition on clean needle exchange, but it doesn't mean that we can't do other work with persons who inject drugs. African Americans. What's interesting about this group and the persons who inject drugs group is that we're quite successful in linking them to care at the same rates, but they are not achieving viral suppression at the same rates. And so we're really trying to understand why. Our Latinx community is late to testing, and we're working on how do we bring them into testing faster. Our 20 to 29-year-olds and our 30 to 39-year-olds, we are not successful in linking them to care as we are with other groups, and we are not successful in seeing viral suppression as we are with other groups. So we need to rethink how we engage these populations. How do we work with them? And then finally, transgender women. We were fortunate to get some funding from CDPH Office of AIDS to do some intensive work with our trans women community. And it was very eye-opening. You know, hi, I'm public health. We're here to help. How can I get you on PrEP? And the answer was, that's not even in my top 10 list. I need access to competent healthcare. I need housing. I need employment. I need lots of other things. And if we're not taking care of people's basic needs, their safety needs, we can't expect them to be successful on PrEP. And so we're really working. Thank you. Yes. So I'm out of time. I'm getting the bum's rush. So thank you so much for your attention. I appreciate it.